Yeah. So person with CD4 of 5 or 10 doesn't mean that he can have only MAC and CMV. He can have
Yeah.
TB also, he can have PCP also, he can have esophageal candida also, toxo also, crypto also. Barabar? So as you go towards the right side or go down towards the stage 3, stage 4, the number of diagnostic possibilities tends to increase substantially, and one patient can have multiple pathogens. बराबर? तो यूजुअली अपन मेडिसिन में क्या करते हैं? किसी को लंग इन्फेक्शन है और मेनिंजाइटिस भी है, तो वी थिंक कि both of them are caused by the same organism. We don't think कि lung will be caused by one infection and brain will be caused by another infection. बराबर? We think that person will be having pneumococcal pneumonia with pneumococcal meningitis. We don't think कि lung में PCP है और brain में TB है, ऐसा नहीं सोचते. We try to explain all the things with a one pathogen and one syndrome. But in HIV with a low CD4, we cannot do that. If person has lung and you isolate the organism of the lung, you can't let the brain go. You have to still do the CSF and rule out other things which can be causing the brain thing. You can't just assume that the same thing which is there in the lung has gone to the brain. Barabar. So this is how the HIV medicine is different from the routine medicine. We have to follow Hickham's dictum rather than Occam's razor. Hickham's dictum, Occam's razor, I must have told you in the past.
Yes,
Have
sir.
I told you? No?
Yes, sir.
Okay.
Yes.
Okay. So now what happens after we start ART? Okay. So what happens after we start ART is that the viral load is reduced by the drugs. So once the viral load comes down, the CD4 starts rising. Okay. So it's like the train is going now in the reverse direction. बराबर ट्रेन आ गया CST से मुलुंड, अभी मुलुंड से वापस CST जाएगा क्योंकि उसको ART मिल गया. बराबर. तो so basically what happens if patient has reached already stage 4, has reached Mulund for example, and he is sort of colonized with a lot of bugs now because his immunity is so low. So as you start him on ART and his immunity increases, the body starts recognizing all of these germs which earlier it was not recognizing. Barabar means HIV positive patient in stage 4 is having CMV in the eye, is having PCP in the lung, is having MAC somewhere in the abdomen, in the nodes or something. Barabar, but his body's immunity is not reacting to them only. His body's immunity is saying, हाँ तुम लोग क्या कर रहे हो, कैसे हो, how are you, you are my friends or what. Body is not attacking it because there is
Person
no
less.
energy to attack and it is not recognizing also. Barabar, it's like our army has decided that Pakistanis are our friends. So even if Pakistanis have entered the body, the army is like, कैसे हो, क्या हो, कैसे चल रहा है, rather than trying to attack them. So what happens is once we give the ART, एक तो वो viral load पूरा कम हो रहा है. Viral load is getting reduced by the drugs. So once viral load comes down, the CD4s, they are already multiplying. But they were not able to multiply earlier because of the virus. Now they are multiplying and there's no virus. So they are increasing in number. बराबर. So अपनी आर्मी वापस जाग गई. अभी आर्मी सडनली जाग गई तो बोलते अरे इतने लोग हैं इधर, चलो मारो सबको. So it starts attacking these bugs, which earlier it didn't even recognize as a enemy. Barabar? So what will happen to the patient?
Severe inflammatory reaction. Inflammatory reaction will happen.
So suppose there is CMV in the lung, but body has made peace with it. Body is not attacking it only. So the patient will not have too much of symptom actually. Barabar? Now body suddenly recognizes it. So it sends all neutrophils and lymphocytes there to attack the CMV. तो अभी वहां पे युद्ध हो रहा है, right? So gray hepatization stage, red hepatization stage होता है ना pneumonia में. That is all due to the immunity also acting, na? It's not just the germs which are there. The immune response of the body causes more consolidation.
Right.
The alveoli will get filled with now neutrophils also, lymphocytes also, and all that fluid and all that will happen. Barabar? So in fact, the patient's symptoms will get worse. Patient will develop fever. Earlier there was no immunity, so there was no fever. Now patient will develop fever, cough, breathlessness. And in fact, the oxygen saturation may worsen after you have started the ART. What will the patient do?
Stop the ART thinking it has caused
Patient
it.
will first kill you. Patient will first kill you. पेशेंट ले मैं आपको मेरा तकलीफ कम करने को आया, आपने तकलीफ बढ़ा दिया. कैसे डॉक्टर हुआ? बराबर? So that is why it is called as a
Paradoxical
paradox,
worsening.
right? Immune reconstitution inflammatory syndrome or a paradoxical response. Barabar? So paradoxically, even though you have given the correct treatment, patients the symptoms will worsen. So after the patient's symptoms have worsened, you have to explain it to him. You have to explain it to him very well that see, this is expected. It's because your immunity is increasing that you are getting the symptoms. It's not that we have given you the wrong treatment or you are having the side effects of that. Barabar? So even when you are starting ART in a patient in stage 3 or stage 4, you have to explain this very well from the beginning only. Otherwise, patient will stop medicine, not come to you, go to somebody else. Or he'll come to you after 3-4 weeks after having stopped everything. By that time, all the ART will get resistant. Right? So you have to be very careful. You have to explain to them that now for the next 2 weeks to 2 months, there can be more symptoms. You may feel worse. But if you feel worse, you don't stop the medicine, you come and show me. I will treat it. But don't stop the medicine. This way you have to explain to them when you are starting ART. That पहला 2 हफ्ता से 2 महीना आपको तकलीफ बढ़ सकता है, पर दवा बंद नहीं करना है. दवा बंद किया तो आगे जाके और तकलीफ होएगा. Right? So now when you have started the ART and the patient's CD4 is increasing, so even the IRIS will be dependent on the initial CD4 what it was. Barabar? But if the patient has come with a good CD4 of 450, 500 and you give him ART, he's not going to develop PCP iris or CMV iris because उसके body में ही नहीं है. You understood? So what iris the patient will develop also depends on the initial CD4 when you are starting the ART. Barabar? So always remember that. So one more thing you have to understand is that immunity increases against the infections, but immunity increases against other things also. So suppose patient has Graves' disease. before he got HIV. Barabar? Grave disease means antibodies against the thyroid. Hmm? Now, when the HIV happened and his CD4 started dropping, in fact, his grave symptoms will reduce. Ophthalmoplegia, ophthalmopathy, वो सब कम हो जाएगा because immunity कम हो रहा है. Then you start ART, then his grave symptoms will worsen. बराबर? So, IRIS need not always be infective. There can be autoimmune IRIS also. Means your autoimmune disease will get worsened after you start the ART. So your rheumatoid arthritis patient है needing a lot of immune suppressants. If he gets HIV, his need for immune suppressants will actually come down. Barabar? Then you start the ART, immunity increases, the need for immunosuppressants may increase. Barabar? So that is rheumatoid arthritis ka IRIS ho gaya usko. Right? Same way, there can be IRIS against the cancers also. The patient may be harboring a cancer and the body will mount some immune response against the cancer. That immune response will go away when the patient develops HIV with a late stage. Then you start the ART, again the body will mount the antibodies against the cancer. So even cancer may get unmasked, which was not apparent earlier after you start the ART. Okay. So generally, IRIS will happen in the first 2 weeks to first 2 months after you start the ART. Barabar. Beyond 2 months is a little rarer, but possible. Generally, it will be 2 weeks to 2 months के बीच में. 2 months के बाद में generally इतना कोई तकलीफ नहीं होता. So IRIS का diagnosis is dependent on few things. हाँ. एक तो patient has to have a lower CD4. You cannot have a IRIS in a patient with normal CD4. You start ART, then you get something. You can't call that IRIS. IRIS has to do with the immunity and the opportunistic infections. And with the rise in immunity, unmasking of the symptoms. Barabar? So, we go to the next slide now. You understood this, no?
Yes.
So, what are the criteria for diagnosing IRIS? Right? See, it's actually not very easy to diagnose IRIS. It can be quite confusing. So suppose patient has come with HIV and some infection. You've started him on ART. The patient develops some new symptoms which were not there earlier. So to call it IRIS, you need some things in your favor. Otherwise, you can't call it IRIS. बराबर? एक तो patient should be adherent with your treatment. पेशेंट ने तुम्हारा ट्रीटमेंट ही नहीं लिया और कोई वर्सनिंग इन्फेक्शन लेके आया तो इट इज नॉट आइरिस. It's a disease progression which has caused a new infection. So first of all, you have to ensure the patient has taken the medicine. Compliance is there. Compliance with ART रहेगा तो ही आइरिस होएगा, नहीं तो नहीं हो सकता. So, and how do we measure this compliance? Viral load should have dropped from the baseline and CD4 should have risen. from the baseline. हाँ, ये दो चीज होएगा तो ही आयरिस होएगा ना, नहीं तो नहीं हो सकता. Then we come to the other criteria. The patient must exhibit a clinical sign and symptom consistent with the inflammatory process. Generally, differential diagnosis of iris are these three things. Okay. So, if you give an ART, patient develops worsening liver function. So it can be iris due to hepatitis B, or it can be liver toxicity due to efavirenz. But to differentiate the two is not easy. So you need this criteria again. Suppose you've started patient on ART, you have ruled out all of infections before you start him on ART. Then after you start the ART, patient develops pleural effusion. So that can be tuberculous pleural effusion. It's one of the common ways of TB presenting as a iris TB. Tuberculous pleural effusion or tuberculous ascites. After we start the ART, patient comes with these things. So differential is that it's not a iris, it may be something else. Whether it is iris or not, these criteria will help you to differentiate. So there can be disease progression, there can be other opportunistic infection, or there may be a drug toxicity. These are the three main differentials. A patient has come with a worsening clinical syndrome after you start the ART. Drug reaction or toxicity, new opportunistic infection, or a disease progression of the HIV itself. Right? To differentiate, you need to see how adherent patient was, what was the baseline viral load, what is the next viral load, what is the baseline CD4, what is the next CD4, and you may need biopsy and cultures and many other things to be sure that this is not an iris or this is not another opportunistic infection and all those things. Okay. So since this differentiation is not easy, we can use these clues. So these clues we use in the TB patient with paradoxical response also. So TB patient with TB but non-HIV patient with TB में अपने को काफी बार confusion होता है. अपने TB medicine चालू किया and the patient symptoms or radiology worsens. So we often wonder whether it is resistant or whether it is a paradoxical response. Especially the paradoxical response in TB happens in the brain and the nodes. It doesn't happen commonly in the other places. Okay. So how to differentiate resistance or disease progression from the iris or the paradoxical response? So these few points can help us. So time course following the ART. Which usually ऐसा होता है कि after you start ART, patient feels better for some time and then worsens. When it is a matter of iris. Whereas when it is a disease progression, the patient will not have any improvement. बराबर. The patient has primary MDR, तुमने TB treatment चालू किया है first line से. Patient will not have any improvement. Whereas iris है तो patient will have initially improvement and then worsen. Okay. Then neutrophilic exudates and histopathology rather than lymphocytic and granulomatous reaction. This indicates iris rather than uncontrolled infection. Improvement is there in the lung, but there is a worsening in the nodes and the CNS. This points towards iris. Person has come with miliary TB and TB meningitis. So you will see that the miliary has improved, but the brain lesions have worsened and the nodes have enlarged. So then resistance is less likely, iris is more likely. Paradoxical response is more likely because lung lesion जाते ही नहीं अगर primary resistance होता तो बराबर. So drugs have been given as per DST. Suppose we had the sensitivity when we started the TB treatment and we have given the AKT as per the DST and then patient worsens, then you are more likely to have iris rather than resistance again. बराबर. So suppose somebody has MDR and you don't know it, you don't have the sensitivity, and you given first line AKT, the patient will not improve. So drugs have been given as per DST, ऐसा लिखा, still patient worsens, so that confirms in a way that okay, this is an immune reconstitution rather than a treatment failure. These are a little complicated, but you will understand it better more and more when you read it. समझ रहे हैं ना सब कि नहीं? You are all sleepy now.
नहीं नहीं.
So improvement then a deterioration, huh? Huh? Sorry, क्या बोला अमित?
मैं वही बोला, बिल्कुल नहीं, सो नहीं रहे.
Okay. अभिषेक सुन रहा है ना?
Yes sir. Yes sir.
Yeah. Okay. So perilesional edema will be out of proportion to the size of the tuberculomas. Lesion with good vascularity seem to respond, and those with a poor vascularity seem to increase. These are all the helpful pointers in iris versus disease progression. So iris we can basically subdivide into two types: life-threatening and non-life-threatening. So you started ART, patient just comes with some enlarged nodes and some fever, nothing else. So that's a non-life-threatening iris. So you can use NSAIDs, you can use steroids, you can continue the ART. Barabar. But if suppose somebody has TBM and you give an AKT for 2-3 weeks, then you are giving the ART. After you start the ART, he gets a very bad CNS iris. When meningitis get worse and exudates get worse and he gets strokes, he gets a lot of dirty things in the brain. Now, this is a life-threatening iris. So in this situation, you may have to give the high-dose steroids and you may have to stop the ART temporarily because the ART has caused a life-threatening iris. Barabar? So in this situation, then you may choose to stop the ART for a while till the inflammation settles down and then start the ART later. Okay. So, we used to have a lot of patients who were not very well educated, whom we used to start on ART during my PG. तो उनको ये आयरिस का कंसेप्ट एक्सप्लेन करना बहुत मुश्किल होता था. हाउ कैन यू टेल देम कि मैं दवा चालू करूंगा फिर आपका तकलीफ बढ़ेगा तो दवा बंद नहीं करना है, आके दिखाना है, ये इम्यूनिटी कैसे समझाऊंगा ना उसको. So my professor used to use this story quite a lot. So you can also use it sometimes. He used to give the example of the Sholay picture. You've all seen Sholay?
Yes.
Or not seen Sholay?
Seen.
Who has not seen?
Seen, sir, I've seen it.
देखा है शोले?
जी सर,
अभिषेक ने भी देखा है?
Yes sir.
ढाप रहा है कोई. सब तीनों ने नहीं देखा है, मेरे को नहीं लगता है.
देखा है सर. देखा है, ओल्ड जमाने का हमने देखा है.
देखा है शोले? अच्छा. तो you can
Yes, sir.
explain in this way, ठीक है?
हाँ.
कि रामगढ़ में
हम्म.
जब गब्बर सिंह का बलबला था So in a way, it was peaceful.
Hmm.
Nobody was dying.
Yeah.
People were just, Gabbar Singh men were just taking the food and going away.
Yes, yes.
There was no violence. There were no people dying. But once Jay and Viru came, there was a lot of violence. दो लोग इसके मरे, दो लोग उसके मरे, इतना सन्नाटा किया भाई, ऐसा सब हो गया ना. So
Yes.
that is how you have to explain कि अभी हमने दवा चालू किया है, मतलब जय वीरू को आपके बॉडी में डाल दिए.
हाँ.
गब्बर के आदमी आपसे लड़ेंगे तो फिर बॉडी में तकलीफ तो होएगा ना थोड़ा. पर इसका मतलब ये नहीं कि जय वीरू को बाहर निकाल दो.
बराबर.
होल्ड ऑन, गिव द ट्रीटमेंट, बाकी और कम. So this is how we explain Sholay, Iris to the less educated person. You understood?
Yes,
Yes,
sir.
sir.
हाँ. So now prevention of iris कैसे करेंगे? पहले तो you screen for the opportunistic infections before you start the ART. If you find any infection, you have to treat it for 2 to 3 weeks, 4 weeks. Only then you can start the ART. So this prevents the iris many times. Okay. So suppose patient has come with a PCP, pneumonia. His CD4 is 5 or 10. Oh, you need to start him on ART. Now you may be very tempted to start the ART immediately. But you should not start the ART immediately because तुमने ART चालू कर दिया तो PCP will worsen and it will be life threatening.
Yes.
समझ रहे हो ना बात?
Yes, sir.
Yeah. So you have to first treat the PCP or the toxo, whichever opportunity infection you got. Minimum you have to give for 2 to 4 weeks that treatment. Only then you should start the ART.
Yes, sir.
The guidelines for each opportunistic infection are a little bit different based on the CD4. कितना तुम्हें रुकना चाहिए before you start the ART. Now, जो 3TC monotherapy holding regimen जो सब मैंने लिखा है ना, that actually is not the standard of care. So don't say this in the exam.
Okay.
That is just a small trick we use. I will explain it to you in person why we do that. But that's not the standard of care. तो ये मत लिखना. बराबर? Now there is a new study which showed that patient is having TB. You have given him AKT for 2 to 3 weeks, 4 weeks. Then you are starting the ART. So giving him steroids when you start the ART at a moderate to smaller dose actually prevents the iris and was shown to reduce the mortality, morbidity.
Okay.
So this can also be done in the prevention. So even though even this is not standard of care, it is part of a large RCT which is found to be useful. So I will share that paper with you later.
Okay.
So now we come to starting ART early. So starting early will prevent a precipitous drop in the immunity, hence prevent robust reconstitution of it. So that is why nowadays all the guidelines have changed. During my time, the guideline was that CD4 350 के नीचे गया तो ही ART देना, नहीं तो नहीं देनी. Now they all say that you start immediately. You rule out opportunistic infection and start the ART as soon as you can. So there's always this little bit of balance that we have to do when a patient has come with a low CD4. Okay, on one hand, you want to start ART early to give him a good mortality, morbidity benefit. जितना जल्दी तुमने किया उतना अच्छा रहता है. but it increases the risk of IRIS. So you rule out by screening for many things and all, and then you start. Versus starting a little bit later. So in this case, you lose some of the mortality benefits of starting early, but you prevent the IRIS also. So baseline workup में हम ये करते हैं, क्यों करते हैं? Okay, these are all the things we do in baseline workup and why we do them. So any person with HIV, I first write all these things, right? So HbS-AG, though, it's very obvious why we do it. We do it because many times HIV, HbS-AG may go together. If person is having promiscuous behavior, right? And also, the treatment you choose may be a little bit different. So HIV, HBV co-infection है. So you want to choose an ART which will work against Hep B also, and it works against the HIV also. So you want to choose two drugs which work against hepatitis B, but will have work as a anti-HIV treatment ART also. So we generally choose tenofovir and lamivudine. You will not choose a non-tenofovir regimen or a non-lamivudine regimen. You want to choose both because patient is having co-infection. So what will happen if you choose a person is HbS-AG positive and HIV positive, but you didn't screen him? And you started him on ART which did not contain the tenofovir. तो HBV फ्लेयर हो जाएगा. या सपोज तुमने टिनोफोविर बेस चूज कर भी लिया तो HBV कंट्रोल में रहेगा. बट जब वो ART फेल हो गया और तुम सेकेंड लाइन ART पे जा रहे हो, you don't know the patient has hepatitis B, you end up choosing second regimen which has lesser Hep B activity, तो HBV flare हो जाएगा उसका. बराबर. So all these things you have to manage. So you have to screen for HbS-AG. There is no choice. Same with HCV. You want to screen for HCV and treat it. Now, why we do antitoxo IgG? Because if it is there, it means the person has been exposed to toxo in the past. So later on in his course of HIV, if he develops ring-enhancing lesions in the brain, then toxo is there in the differential. Otherwise, toxo is not there. Right? Then empiric, so many of the guidelines say that empiric anti-toxo treatment dena chahiye if a HIV positive patient has come with a mass lesions in the brain. But that's if the anti-toxo IgG has been positive in the past or it is positive now. So if the anti-toxo IgG is negative, then it helps you in the differential later on saying that, okay, this brain ring enhancing lesion in the brain cannot be toxo. Secondly, if the person is anti-toxo IgG negative, then you want to keep him negative so that later on he may not develop this thing. So you'll also counsel him to avoid cat exposure and feces and all. CD4, why we need to do it's very obvious. Differential diagnosis is CD4 dependent. Will help in gauging whether person is developing IRIS or not later on. It will determine whether TMP-SMX prophylaxis is needed or not. What is the problem if we don't do it? Difficult to judge current state of the immunity. कौन से स्टेशन पे है ट्रेन यही नहीं समझेगा. फिर वायरल लोड क्यों करते हैं? Gives an idea of the pace with which further immune suppression may occur. It's difficult to determine IRIS if you've not done a baseline viral load. If the viral load is low, but CD4 has come down, so it may indicate that person is having HIV-2 maybe, not HIV-1. There are two types, HIV-1 and 2. Right? ये अब थोड़ा पढ़ लो. As a part of baseline workup, we always do X-ray and sonography also. Basically, this is to screen for the opportunistic infections. If they are there, we have to treat it before we give the ART. Additional baseline workup which we do when the CD4 is less than 100, are these two: right? Serum cryptococcal antigen and a fundoscopy. Right, fundoscopy for looking for the CMV retinitis, because if it is there, we can treat it. And if we have not looked for it and we start ART, then there can be IRIS uveitis, IRIS CMV retinitis, which can be sight-threatening. So if patient has come, HIV positive, you've done the CD4, it's come less than 100, don't start ART before you've done a fundoscopy. It is a part of the baseline. हाँ, ये सब बहुत छोटे छोटे important चीजें हैं, but practically they are very important. This should be by heart, like otherwise you can't practice HIV. ये सब तुमने कहीं भी छोटा भी गलती कर दिया ना, आगे जाके it really bites you. Okay. With that, I think we'll stop. So now you have a basic understanding of HIV, the concepts, and the IRIS, and the prophylaxis, and also the baseline work of why it is done, all that. Okay. This time we'll go into more of ART and then maybe lung infections. Okay, hope this was useful to you guys.
Very
Very
useful.
good.
Thank you so much.
Thank you, sir.
No problem, no problem. Bye. Enjoy.
Bye.
Bye, sir. Thank you, sir.
Bye.